Thank you very much for this kind invitation and allowing us to share our experience regarding what is a very challenging and difficult topic. And before I start, I just want to convey some of the challenges that we see and face, and that is that in pediatrics, the bladder is continuing to evolve. It hasn't matured, and depending on the age at which you're considering a renal transplantation, I think we have to sometimes not just do one assessment, but a series of assessments. And a common scenario for us is that a child's renal function is fairly fragile. We are told he's being worked up for a transplant or she's being worked up for a transplant. And if appropriate, they'll have invasive urodynamics. And then the renal function stabilizes for a long period of time, a year, sometimes 2 years. And then 3 years down the road again, it's being revisited, and obviously the child's bladder function has evolved during that period. So therefore, from our side, we would always keep our minds open and not make a firm plan based on a single assessment. Okay, so the principle of management, at least from our perspective, is that we should take all necessary steps to ensure that you have a safe urinary tract prior to renal transplantation. Now, we should just keep in mind the urological conditions that are associated with significant renal as well as bladder dysfunction. And certainly when I started training, augmentation was very commonly being carried out for 3 conditions. The first was posterior urethral valves, the second was bladder exstrophy, and the third was the neuropathic bladder. Over time, I think that there have been improvements in the management of some of these conditions, and therefore our incidence of offering and carrying out augmentations has reduced considerably. So these are the conditions that are associated with quite significant degree of bladder dysfunction, which can have an impact on the transplant. And the one thing that we are looking for, obviously, is to identify and then appropriately treat, as Imran illustrated through some of his case studies, the hostile bladder. What do we mean by a hostile bladder? A hostile bladder is one in which the compliance or the pressure under which the urine is being stored is significantly high, and greater than 30 centimeters for expected bladder capacity would be considered a poorly compliant bladder. A leak point pressure, which is more than 40 centimeters of water, is also associated with a high risk of renal damage. Detrusor sphincter dyssynergia can be associated with significant back pressure changes and cause renal damage. Secondary vesicoureteric reflux, incomplete bladder emptying, which is associated with the risk for urinary tract infections, and these are all the factors that we would be looking out for. So the assessment starts, as in most cases, with a good history. Antenatal history will give you a clue as to what may have been the underlying problem. Subsequently, going back to some of the questions in the earlier talk, it's quite important to know whether the children attained continence, had normal toilet training, and if they were reliably dry, both during the day as well as at night, and subsequently ended up in renal failure. History of urinary tract infections, and of course, most importantly, any previous surgical interventions. We would, along with the bladder assessment, also look at the results of radiological investigations where appropriate. And in pediatrics, whether you're doing a non-invasive or an invasive assessment, it is a combination of art as well as science. Okay, so children, when they come for these assessments, it's an alien environment, and they may not necessarily replicate what happens in a normal day-to-day situation, which is why usually we would carry out certainly more than one non-invasive assessment, but also take into consideration other random incidents where they come in, for example, for an ultrasound of the urinary tract, an MCUG, and take all the findings into consideration. If you've got consistent evidence, for example, of incomplete bladder emptying, across all your investigations, then that's very likely to be a significant problem. Assessment of bladder function. Going back to Steve's question, I think I would agree that it's important to distinguish between urological and nephrological causes of end-stage renal disease. But also it is very important to consider the age at which you're considering transplantation. Particularly with urological conditions, as I alluded to earlier, there is an ongoing evolution, not just in normal bladder function, but also with the specific conditions. And therefore, assessment and planning would be based on these factors. For the nephrological causes, generally these are not associated with a significant degree of bladder dysfunction, and certainly to have hostile bladder dynamics would be uncommon. Urinary tract infections and urinary incontinence tend to be the main problems if bladder function is abnormal. Usually a history, physical examination, imaging, and non-invasive bladder function assessments are sufficient to make a plan. And the need for invasive urodynamics in this group of children is uncommon. So moving on to the urological conditions, I think we'll just consider them individually and see what the risk is in terms of the bladder dysfunction. So looking at children with posterior urethral valves, which is quite a common problem, we still get anything between 25 to 30 new cases each year. And what is recognized about the evolution of bladder function following successful valve ablation in these children is that very early on, these children, the bladders tend to have a reduced functional capacity. They have detrusor overactivity, but the compliance is usually unimpaired. They tend to void with elevated voiding pressures, which are typically in the region of 120 to 150 centimeters, and bladder emptying isn't always to completion. As they get older, between the ages of 4 and 7, their bladder capacity tends to increase, the detrusor overactivity tends to resolve, and voiding pressures start to normalize. They empty quite efficiently, but some degree of post-void residual is not uncommon. And late, so once they are into their late teenage and early adult life, it is recognized that a proportion of these children will develop a large bladder capacity, their voiding pressures will reduce over time and will be associated with significant post-void residuals, what is described as a decompensated bladder. In addition, there may or may not be associated ongoing reflux. Looking at the natural history and evolution of bladder function in children with primary vesicoureteric reflux, generally early on they tend to have a good, if anything, large functional capacity. They may have some detrusor overactivity, but the bladder compliance is unimpaired. Their voiding dynamics tend to be immature with poor coordination between detrusor contraction and sphincter relaxation and incomplete bladder emptying, either primary or due to the ongoing reflux. In older children with primary vesicoureteric reflux, they tend to have large capacity bladders, which are generally stable and compliant. They have decompensated voiding dynamics with reduced voiding detrusor pressures and tend to leave significant post-void residuals. Moving on to the third group, and that is the open spinal dysraphism, which is the myelomeningocele typically. It is well recognized that this condition is associated with a significant degree of renal damage. And it can be quite dramatic. One single urinary tract infection can sometimes completely destroy a kidney. And approximately a quarter of these children end up with significant renal damage and may subsequently require renal replacement. So looking at the bladder dysfunction in this population, essentially there are four classic patterns that are recognized. The first one on the top left, which is the DSD, and that's seen in approximately a third of this population, is the most dangerous because this is one where you've got a reduced functional capacity, detrusor overactivity, compliance is impaired, and then during voiding they have a detrusor sphincter discoordination, which usually is associated with secondary reflux and renal damage. The one on the right, the overactive detrusor with the underactive sphincter, is a problem for continence, and that can be addressed at a later stage, but is unlikely to be associated with significant renal damage. The underactive detrusor with the overactive sphincter, here the problem is going to be of bladder emptying because they tend to have a large capacity but not enough contractility and an overactive sphincter, and typically these children would end up with intermittent catheterization. And then the underactive sphincter with the underactive detrusor is an issue of continence, which will need to be addressed once the child is older. So the hostile bladder is the one that we are constantly on the lookout for and needs to be appropriately treated, whether that is with anticholinergics and clean intermittent catheterization, whether that is with urinary diversion, or in selected cases, bladder reconstruction. Anorectal malformations, again, typically the bladder dynamics following corrective surgery essentially stay unchanged. And the higher the lesion, the greater the risk that it is going to be associated with associated spinal anomalies, and that can lead to potentially hostile bladder. The cloacal anomalies are, again, a very rare group of children. And typically, the historical studies have shown that in the long term, these bladders tend to have decompensated dynamics post-surgical intervention. There have been some recent changes recently in the approach to the initial surgical reconstruction, and we are continuing to monitor these bladders to see whether there is any change in their long-term outcome. Rhabdomyosarcomas, again, depending on the type of treatment, whether that's brachytherapy, whether that's conventional radical surgery, end up with some degree of bladder dysfunction, and they typically tend to have a reduced functional capacity with detrusor overactivity, can have impaired bladder compliance with elevated voiding pressures and incomplete emptying. So potentially, again, this group of children are associated with hostile bladder dynamics. Other rare conditions like tuberculosis, etc., have the potential, and it is important to recognize that this is something that can have an impact on the bladder and therefore carry out appropriate bladder assessments to address this. So, as we've talked about several times already, the most important question that the nephrologist wants to know, that the transplant surgeon wants to know, is from the urologist, is the bladder safe? Can you give me in writing that it is okay for me to go ahead and transplant this child with reimplantation into the bladder? So we typically would tend to start out with non-invasive bladder function assessments, and that not only serves as a baseline, but can also serve in ongoing follow-up depending on what interventions or medications have been suggested. It helps us to direct treatment or modify treatment, and more importantly, it will identify the patients who would benefit from more invasive studies where appropriate. You probably are very familiar with these different types of flow curves. That's your normal bell-shaped flow curve. That's a tower-shaped flow curve, which suggests some degree, possibly, of detrusor overactivity and urgency, and typically this would be associated with urinary incontinence. The interrupted flow is suggestive that the bladder may be decompensated and they are using abdominal straining in order to try and efficiently empty the bladder, which can be fairly successful when they are young, but would tend to become a problem, particularly once they are post-pubertal. The staccato flow, that's telling you that you've got a significant degree of detrusor sphincter discoordination or dyssynergia, depending on whether there's an underlying neurological lesion or not. And then the plateau flow, which is typically associated with some degree of fixed resistance or obstruction, whether that's a meatal stenosis, whether that's a urethral stricture, and basically would prompt you to look for any correctable obstructive lesion. Moving on to the invasive urodynamics, I think it would be fair to say, and I'm happy to be corrected, but I think for most urological conditions, at Great Ormond Street, we tend to ensure that these children have had an invasive urodynamic study prior to renal transplant. I think for the for the nephrological causes, I think it would be uncommon, but for almost all urological conditions, we would ensure they have invasive urodynamics. And depending on their age and depending on the underlying condition, we have different types of studies that we carry out. For the babies, so the really young children, we carry out what is called as natural filling urodynamics. For the older child, it's either a standard filling artificial cystometrogram, or where we are also interested in looking at anatomy, presence of diverticuli, presence of reflux, we would carry that out using radio contrast in a video urodynamic study. So, as the name suggests, it requires the presence of catheters, a rectal catheter for abdominal pressure recording, and a vesical catheter for intravesical pressure recording. Again, typically, which is probably a little bit different to a lot of other centers. We tend to do the vast majority of our invasive urodynamics through suprapubic catheters, which requires an anesthetic a day before we are doing the study. And I have faced quite significant questions over this approach, but there are sound reasons why we think that this is a better technique. The first is depending on the age of the child. So typically, barring the natural fill that we do in babies, most of them would be around 4 to 5 years of age before we would consider invasive urodynamics. The lumen of the urethra at that age is quite narrow. If you then put a urethral catheter through it, a 7 French or an 8 French double lumen, I think you're further compromising the outlet. In addition, we've burnt our fingers in the past, particularly with the neuropathic population, where we've done a study through the urethral catheter, because typically a lot of these children tend to be catheterizing anyway, and so it doesn't make sense to subject them to an anesthetic. However, what we found on occasion was that the outlet resistance is sometimes more difficult and is in fact artificially elevated by the presence of a urethral catheter. So the children then went on to have their augmentation, Mitrofanoff, ACE, and they came back 3 months later for follow-up and they said, still wet, constantly leaking. So we, as I said, generally tend to do it through suprapubic catheters. And obviously, in the filling phase, the things that you're looking out for is presence or absence of detrusor overactivity, what is the compliance of the bladder or the system, bladder capacity, presence or absence of sensations, any associated urgency, any leakage, and if it's a video study, whether there is any vesicoureteric reflux. In the voiding phase, you're looking for hesitancy, pattern, so more or less that would correlate with your flow rates. What's the maximum detrusor pressure? What's the maximum detrusor pressure at maximum flow? Is the flow continuous? Is it interrupted? Is there any reflux? What's the bladder neck function doing? Is the urethra looking normal? And is bladder emptying good, or is it incomplete? And if there is reflux, is there secondary refilling? So natural filling urodynamics, just very briefly, as I said, the applications for this type of study is generally in babies in a clinical situation. It's very time consuming, typically takes about 4 hours, and you need to record at least 2 filling and voiding cycles. So therefore you can imagine in a young adult who's got a capacity of 600 or 700 mils, this is not a good approach. And typically it involves a single catheter in the bladder. The bladder will fill naturally from the kidneys, and obviously you need a rectal catheter for abdominal pressure measurement. Advantage is you can carry it out in babies who are in a cot, toddlers who are ambulatory, you just strap the thing to their waist and off they go and come back. At least one of the cycles, it's important to observe what their voiding is like. The standard artificial filling cystometrograms, advantage is that it can be done in privacy. You don't, unlike in the video setting where you've got 3-4 people in the room, this can be done behind a curtain, and so therefore you're much more likely to get good cooperation from the children. Disadvantages are you obviously don't get any fluoroscopic imaging, and so if you are concerned about reflux, outflow obstruction, you would need other imaging modalities to answer that question for you. And then situations where you want information on both anatomy as well as function, you would prefer to go for a video urodynamic study. So coming to bladder management options, and I think through Imran's talk, and we've discussed various possible advice that may be offered from the urological side. So the ideal scenario is you've done your thorough assessments and you've deemed the bladder to be safe, and so you say, this bladder is safe to receive a transplant. Fantastic, no problem. The second situation is that your bladder capacity is reasonably good, compliance is not an issue, the bladder is stable, but the bladder emptying is ineffective or they're leaving behind significant residuals. At a young age, children can compensate for this by practicing what is called double voiding, which means basically you ask them to go and empty their bladder, and then after a gap of around 10 minutes, you ask them to go back and try and empty again. And sometimes that's more efficient if they do it sitting down. The third situation, which Imran alluded to, I think in one of his cases, is Overall, the bladder seems to be reasonably good, but either because the child is a bit oliguric, you can't be 100% certain about how that bladder will cope once the transplant is in, once they are on a fluid target, and there's a lot of urine going through the system. So we recommend in those situations to put in a suprapubic catheter when they're doing the transplant. And then once the transplant has settled, we would then typically about 2 weeks after the transplant start clamping and releasing and assess the bladder function, see how the bladder is coping, and see how well the bladder is emptying. There is, of course, a role for offering and advising that the children start clean independent catheterization with or without anticholinergics, depending on what the bladder assessment has shown. Now, urinary diversion is, I think it would be fair to say, is not very uncommon in our practice, and we do offer it in selected situations. If possible, refluxing ureterostomy, typically because it tends to allow the bladder to continue to cycle and the bladder function to continue to evolve. And certainly there are 2 children that I continue to look after at the moment, one of them is about 7 or 8 years post-transplant, had a hostile bladder that was identified underlying condition was posterior urethral valves. He was too young at that time for an augment, and so he had a refluxing ureterostomy. He is now so comfortable with that, in addition to the fact that there are some psychological issues because he's had problems with his hips, has had bilateral hip surgery, etc., that 8 years down, it is now, every visit is about trying to convince him because he's still wearing nappies, he's 12, 13 years of age, and that needs to obviously change. We've repeated his bladder dynamics to see if there's been any change over this period of time, and unfortunately there hasn't. And I think he's on the path now and is being prepared to have closure of that, obviously refluxing ureterostomy, an augmentation, and a mitrophanol. And then the definitive solution in a proportion of children, certainly in our practice, remains bladder reconstruction with or without an associated mitrophanol or an ACE. So it certainly still has a place in our practice, and we continue to offer it in selected cases. Coming to urinary tract infections, again, a lot has been said, a lot of surgical solutions have been offered. And we've also accepted that every once in a while we are in this frustrating situation where, despite trying everything, we are unable to overcome that. But there are some correctable risk factors for urinary tract infections that we must look at and address aggressively if necessary. In male children with an abnormal urinary tract, it has been documented and demonstrated that circumcising them certainly reduces the risk of recurrent urinary tract infections. Vesicoureteric reflux is well recognized as a factor that increases the risk, and that may be either into the native or into the transplant kidney. Incomplete bladder emptying, again associated with significant risk of urinary tract infection. Constipation, urinary stasis, for example, poor drainage in a non-functioning kidney with hydroureteronephrosis. And finally, look for foreign bodies, things like calculi, presence of stents, indwelling catheters, buttons, etc., and see if these are the precipitating factors, if there can be any alternatives. Adjuvant measures, good fluids, good fluid intake, probiotics, cranberry, managing the bowel as best as you can, and ensuring that you have regular and complete bladder emptying. And certainly it was reassuring for us to see that, auditing the outcome of the renal transplants in those with urological and non-urological underlying causes, I would be brave enough to say that I think our assessment and management seems to be reasonably good, because I don't think there is any significant difference long-term in graft survival. Thank you very much.
Thank you very much, Divyesh, for an excellent presentation. Questions? Silence. Well, very briefly, one question. I know at Evelina they do bladder assessments for everybody, including the non-urological cases, and they found a small proportion, I can't remember the exact figure, where basic urodynamics show abnormalities. What's your feeling about that?
So I think we do tend to carry out an assessment if there is either urinary incontinence, mild or occasional, or if they have urinary tract infections. In a child who is completely well, successfully toilet trained, reliably dry, day and night, ultrasound scan showing normal kidneys and complete or near complete bladder emptying, the possibility of finding underlying bladder dysfunction is very low. So, and that's why I alluded to the fact that you don't just rely on one test, which is the bladder function assessment, but you look at, a lot of other things and then add that to because certainly the younger the child, in our experience, more often than not, a single bladder function assessment is not going to show you what typically this child does. So to rely on that is fraught with error.
Thank you so much.